Welcome to Persyst Grand Rounds, an online series of lectures hosted by Persyst covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Katie Colbreeze, and I'm here today to introduce our speaker and topic for Persyst Grand Rounds. Slide, please. Perfect. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow toward the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. Please visit www.persyst.com/grandrounds to keep up to date, and the schedule is subject to change. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interests. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. Okay, thank you. There will be time for questions after the talk, so please write your questions in the Q&A area. There's a button at the bottom of your screen. We welcome as our speaker today, Dr. Pilar Pichon. Dr. Pilar Pichon is a Health Sciences Associate Clinical Professor in the Department of Pediatrics at the University of California, Irvine, and a board-certified child neurologist and pediatric epileptologist at Children's Hospital of Orange County, California. Dr. Pichon is a graduate of Albany Medical College in New York. She did her pediatric and child neurology residency training at Loma Linda University. She obtained her fellowship in clinical neurophysiology with emphasis in pediatric epilepsy from Emory University, Children's Healthcare of Atlanta. She did her elective in interoperative monitoring. She also immersed herself in educational opportunities at the Marcus Autism Center, one of only 5 NIH-designated autism centers of excellence in the country. Her special interests include epilepsy, epilepsy surgery, and autism. She collaborated with UCLA researchers to study the visual processing of children with Tuberous Sclerosis Complex. She was awarded a research grant to study neurodevelopmental outcomes of children with congenital heart disease. She advocates for children and their families to obtain the best care and services that they need. Dr. Pichon will speak on epilepsy and autism, the role of EEG and neurodevelopmental disorders in clinical practice. Please join me in welcoming Dr. Pilar Pichon.
Good morning, everyone. I will be talking about epilepsy and autism, two topics that are very close to my heart. And if we have time later, I can give you just a little bit of hint on how I foresee the future looks for this shared field of interest for me. I have interests, as I told you, and I'm with the Inland Empire Autism Assessment Center of Excellence as well. And I just established, along with the Thompson Autism and Neurodevelopmental Disorders Clinic, the CHOC Rett Syndrome Clinic. So this talk will delve onto epilepsy, autism, and the neurodevelopmental disorder that I picked is Rett syndrome, because that is also where the intersection of epilepsy and autism is very evident. So this is just from the Epilepsy Foundation website that I think most of the neurologists and the epileptologists use for their education for the patients. So I think I give credit to Dr. Khan who wrote it, and I think it's very on point in terms of the relationship of epilepsy and autism. So the first question is, what is epilepsy? And this is at the level of our patients, the information level that we share with them. So we describe seizures as abnormal electrical firing from the brain. And then what is the definition of epilepsy? From Dr. Khan's writing, she wrote it as recurrent seizures. But from my viewpoint, as someone who does autism as well, Epilepsy is kind of like an umbrella diagnosis, just like autism spectrum disorder is. So you have the EEG data, you have seizures on the EEG, you have the risk for seizures, as well as the other coexisting conditions that comes with having a seizure. So if they have an underlying genetic disorder, if they have an underlying neurodevelopmental disorder, just like in autism, where we say that a child meets criteria for autism spectrum disorder with a genetic disorder of such and such, I tend to put that in my diagnosis for epilepsy if I know what the etiology is. So let's say if the etiology is genetic or if the etiology is structural, then we put that there as well. And then I think this is important to note that approximately 1 to 2% of children in the US are diagnosed with epilepsy. So when you switch to autism spectrum disorders, it's even higher. So the diagnosis has been about 1 to 67%, but in some areas, it's even they're thinking 33. I mean, 1 in 67 children. In other areas, their studies show that it's probably higher, 1 in 33 children. So ASD itself, it's about 1.5% of children in the US have ASD. So 2% with epilepsy, 1.5% of children have ASD. And then the other part of my talk today is Rett syndrome. So maybe it's seen in about 1 in 10,000 to 40,000 children. So we're kind of going from a bigger view and then we're honing in into a neurodevelopmental disorder. So what is the association between epilepsy and autism? I try to be creative when I ask children to do hyperventilation. So I've gotten into blowing bubbles now. Before, during COVID, I would have them blow the wipes. And I said, you can stop blowing until the wipe is dry. So I'm back to the bubbles. So children with autism are more likely to have epilepsy. And children with epilepsy are also more likely to have autism. Seizures are the most common neurologic complication in ASD. And that is one of the reasons why I have always been interested in these two entities. And approximately a third of the children with autism have epilepsy. So that's a huge number. If we have the incidence of autism as 1 in 67 children, a third of them have epilepsy. So that's also a considerable number of children with both autism and epilepsy. So the green slides are basically the current clinical guidelines. And since this talk is limited to clinical practice, I just kind of want to trigger your memory just in terms of these common accepted knowledge. So about 2 decades ago, Dr. Ashwell and his colleagues wrote the clinical parameters and recommendations for practice guidelines for children with ASD. And in that clinical guideline, EEG was not recommended as a screening tool for epileptiform abnormalities. So I hope that through this talk, I can convince you that there is a utility for EEG, at best a routine EEG for children with both autism and epilepsy, and also even with children with just autism. So these are the 3 organizations that have come up with their guidelines as well. They would recommend EEG, the Child Neurology Society, for clinical seizures or history of regression. So if they have autism and then clinical seizures or history of regression, then you can do an EEG. But if they have neither of this, then you don't have to do an EEG for a child with autism. The National Institutes of Health and Clinical Excellence had a clinical guideline for autism, and they said you can do an EEG if you are suspicious for epilepsy in that patient. And it's the same thing for the American Academy of Child and Adolescent Psychiatric Practice parameter. They said that if there are unusual features in the child, such as history of regression, dysmorphology, staring spells, and a family history of epilepsy, then you can do an EEG. So I bet you that in most of our practices, this is what we do follow. So this is an article that came out in 2018 where they studied EEG in autism. So they excluded a lot of the, it's a meta-analysis, they excluded a lot of the patients that we typically associate with autism and epilepsy, the stereotypical patients. They excluded children with tuberous sclerosis. They excluded children with genetic diagnosis that predisposes them to both epilepsy and autism. So basically, their focus for this analysis was just the tool, the using EEG as a screening tool for children with ASD who do not have a coexisting condition that predisposes them to epilepsy. So just to simplify it in my head, I call this as the autism minus epilepsy group. So they also excluded papers that examined epilepsy and ASD. They excluded papers that talked about evoked potentials, quantitative EEG, which is what we use Persyst for, and polysomnography papers. And they started with 33,110 articles on ASD. And as they excluded all these studies, these papers that have these 4 blue things that I listed here, they came up with about 25 papers that they analyzed. So from 33,110 to 25. And so what did they learn from those 25 remaining articles or remaining studies? So they highlighted the need for screening EEGs for children with ASD, even those without epilepsy. So ASD minus epilepsy. And they noted that EEG would assist in differentiating epileptiform discharges from the core features of autism. And we do see impairment in social interaction, for example, in social communication in autism. So if you try to talk to a child with autism, for example, they may not communicate with you, they may look past you, and they may have these, what looks to you and me as staring spells. So how do you distinguish that behavior from an absence seizure, from a generalized seizure, or a focal seizure with impaired awareness, for instance? Without an EEG, you cannot. And we are only about 50% right at guessing whether a behavior is a seizure or not. And they recommended from these 25 studies that EEG should be included in a comprehensive assessment. So the 3 primary and well-documented findings to support screening children with ASD, these are from the 25 articles, these are the things that came up. ASD and epilepsy are more connected than previously believed. And I think if you are in clinical practice, you will agree with these findings from them. And then epileptiform discharges are highly prevalent in children with ASD. So about 30% of children with ASD minus epilepsy can have epileptiform discharges. And these discharges are also more common in patients with significant comorbid psychopathology. So let's say in my Inland Empire Autism Assessment Center clinic, if I just randomly do an EEG on my patients and they have an underlying coexisting psychopathology, for instance, most of them have ADHD, or if they have anxiety, my pretest probability for an epileptiform discharges in this cohort is high. And I have seen that as I have ordered EEGs for some of them. I've seen about maybe 1,000 kids that we've evaluated there. And the third point is those children with ASD have demonstrated evidence of epileptiform discharges, have increased likelihood of developing epilepsy in adolescence. So even if they present to you with ASD without epilepsy, if they have epileptiform discharges, then you have to be on the lookout. When they do hit adolescence, sometimes they end up developing epilepsy. Unfortunately, some of us don't have the privilege of being able to follow these children through adolescence because some of them move or we move. So it's important that we put it in our note that if we haven't considered EEG, then maybe consider EEG if our suspicion is high for epilepsy risks. And your history and physical is very important. So going back to the previous slide from the psychiatry group parameters, if there is anything unusual with a child, dysmorphism, if there's a family history of epilepsy, then definitely keep the EEG as a tool in mind, not even if it's not during the time that you see them, but also in the future. So as I told you, the green slides, if you don't remember anything from this talk, just try to remember the green slides for me. So ASD patients have similar epilepsy syndromes or seizure types and ictal features as non-ASD patients. So this time we're comparing our ASD patients plus epilepsy and your non-ASD patients who have epilepsy. And there is a higher ratio of females to males, 7 to 8, than in the general ASD population, so 1.3 to 1.4. So this is interesting because this is different from the prevalence that we see in ASD alone. It's more prevalent in males. But this was also seen by one of my mentors, Shefali Cheste, in 2015 when she studied children with refractory epilepsy. So she was more into looking at biomarkers for tuberous sclerosis, where the clear intersection of epilepsy and autism is found. And there's higher ratio of females to males. And that was one of the reasons why I picked Rett syndrome, because in Rett syndrome, there's also a higher ratio of females. And in the cohort of the next study that I'm going to show you from New York, they had 70% of their patients as children and 30% of them were adults. So just bear in mind, I'll be presenting some adult EEG as well. So this is the retrospective study of 400 consecutive patients with ASD and epilepsy in a level 4 epilepsy center between 2015 to 2019. This was headed by Dr. Davinsky. And so this is now looking at the ictal EEG in patients with autism spectrum disorder and epilepsy. So before we looked at ASD minus epilepsy. So now we're looking at their cohort of ASD plus epilepsy. So they had over a 4-year period. So they had 45 patients who had at least one EEG recorded seizure captured. So the type of EEGs that they did, they had routine EEGs, they had ambulatory EEGs, and they also had long-term monitoring admissions in the EMU. A total of 497 seizures were captured, and 20 patients had focal onset epilepsy, and these 20 patients had 126 seizures. 17 patients had generalized onset epilepsy, and of this 17 patients, they had 88 seizures. 7 patients had Lennox-Gastaut syndrome who had a high seizure burden, as we all know. They had 270 seizures. And there was one patient who had both right hemisphere focal and generalized onset seizure. So just the numbers, 45 patients, okay, who had at least one EEG recorded with seizures in them. And this was by Alimo. They excluded patients with known genetic conditions. So this was similar analysis as the first study, the first review that I showed. So they excluded the ones with a genetic diagnosis, and they excluded patients with what they termed acquired pathology, those who had cerebral palsy and tuberous sclerosis complex. For patients who met criteria for ASD and epilepsy, medical records were reviewed for demographics, age of non-febrile seizure onset, and age of ASD diagnosis. And they also looked at their language abilities in terms of their verbal abilities, and if they have limited speech or if they're nonverbal. The neurodiagnostic data that they reviewed included MRI, genetic testing, and EEG reports, and they also did look at the EEG raw data. So how did they define ictal EEG in patients with autism spectrum disorder and epilepsy? So they defined it as follows. The ictal onset was documented by the presence of repetitive epileptiform activity, or they termed it as REA, and rhythmic activity. And they also looked for the presence of rhythmic delta, theta, alpha, or beta waves. And this is their summary of the individual seizure classification and duration for the patients who have epilepsy and autism. And so it's similar to what we see in the autism group or the epilepsy group. So they have the focal seizures, children and adults with focal seizures, and children and adults with generalized seizures, and also children and adults with Lennox-Gastaut syndrome. So if you look at the numbers of seizures and you have the patients listed here, so focal impaired aware was the most common focal seizure in this cohort. And then in terms of the generalized seizures, it's very diverse what they found for the motor generalized seizures. So they had one with atonic, they had 2 patients with epileptic spasms, and then myoclonic and tonic, and then 4 with tonic-clonic. So in general, from this group, the most common seizures that they found was tonic-clonic seizures, so mostly convulsive seizures for the generalized. And then for Lennox-Gastaut, the Lennox-Gastaut group, as we all know, we have the different types of seizures as well. So atonic, clonic, myoclonic, tonic, and tonic-clonic and eyelid myoclonia, but the most common seizure type for the Lennox-Gastaut, which we often see in our practice, are the tonic seizures. And there was also non-motor seizure in the Lennox-Gastaut group. So I think just in general, this cohort that they have of the 400 patients is pretty similar to what we see in epilepsy alone group. And this is just a graphical representation of what they saw, that they divided it by age group. So for instance, in the toddler age group, the most common seizure are actually generalized seizures. And the same thing for the adult group. The most common are generalized seizures. But in between for preschool, pre-adolescence, adolescents, usually in the adolescence group, for example, the most common are the focal seizures. So I think that the adolescence group is a very interesting group in terms of those who have ASD and epilepsy, because we find that if they do have seizures, the seizures tend to get worse during adolescence. And some speculation, or maybe we've accepted it, that in adolescence, you have all these hormonal changes, and they can increase the seizure burden at that point in life. So this is just an example of an EEG in an adult, a 46-year-old who had a clinically generalized onset seizure. And you see this high amplitude generalized spike in waves with single 1 Hertz delta wave and delta activity. And then you see some generalized spike wave complexes in a burst. And also this patient does have the head drops, and they usually happen here on the first few seconds. So the reason I showed you the EEG is because I know we all know about the 3 Hertz spike in waves for the generalized seizures, but this is just an interesting pattern that we see in a clinically generalized onset seizure in an adult. So bottom line, there are no specific seizure type associated with ASD in this population. So as you can see, it's about close to equal in terms of how many of them have had generalized seizures and how many of them had focal seizures. And there are diverse seizure types and interictal EEG abnormalities in the ASD populations, just as we see in the general epilepsy population without ASD. And interictal EEG abnormalities often occur in ASD patients without epilepsy, as we've already talked about before, and they may contribute to cognitive or behavioral disorders. So this is where I think some of these tools that can quantify the the frequency of the interictal EEG abnormalities can help us as we engage in clinical trials or clinical studies to see how the frequency of these, even this interictal EEG abnormalities, correlate or maybe contribute to the impairments that we do see. So I want to give you a break. You can go get a glass of water or something, but I think that this is a better way of introducing you to the Rett syndrome as we shift into a smaller cohort of children with autism and epilepsy.
Our pregnancy was completely fine. There was nothing wrong. She had a score of 9 point something as an APGAR in the hospital. When we left the hospital, we thought we were taking home a perfect child.
By 9 months old, she was not sitting up. She was not doing tummy time. She was not pushing up, crawling. And that's when we started fighting, trying to find the answers and figure out what was causing her pain.
We saw many, many different specialists, but nobody could explain what was going on with Katie. And then a neurologist suggested that perhaps we needed to test for something called Rett syndrome.
Rett syndrome is a disease that primarily affects girls, and it causes them to lose the ability to speak and use their hands after a period of time in which they were developing this normally.
One day they wake up and they begin to lose their skills one by one. Every single system in their body is affected.
Rett syndrome is a very interesting genetic disorder. It is not inherited. It's essentially a new mutation each time it occurs.
The greatest challenges are different from child to child affected by Rett syndrome because every child is different. Every child has a unique combination of issues.
These children who become teenagers, who become women, need 24/7 care for their entire life.
She does not walk. She does not talk. She has a lot of the repetitive hand motions. The constipation is really a problem.
She slowly developed feeding problems and reflux. So we had to address that with medications. She couldn't drink fluids anymore. She would choke on them and gag. So we had to get a feeding tube.
She hyperventilates and breath holds. Sometimes the breath holding does affect where she turns blue.
She got scoliosis. So last summer she had to have scoliosis surgery. Then we do some post x-rays and her doctor's like, oh, by the way, she's got hip dysplasia. I'm just like, it sucks.
The emotional burden is really the hardest part because you're constantly worried about if she is happy, comfortable, fed, hungry, worried, sad.
For 6 months after our diagnosis, it was just a very dark, lonely time with fear, a lot of fear. And there's light at the end of the tunnel, and that was given to us in the form of RettSyndrome.org.
Our community yearns to know each other and to be connected. There is so much love and joy amidst the tragedy and grief. Everybody wants to know each other and talk about their child. Nobody wants to keep our girls a secret.
These girls are smart. They know what's going on. They know what you're saying. They're capable of learning. They're capable of loving. They're capable of having friends.
In May, Anushka got President's Award for Outstanding Academic Achievement. The whole school gave her a standing ovation. And it's the day we will never forget.
My hope is more and more people will become interested in this disorder and will join the team. Everyone is going to be rewarded because seeing one of the girls smile, seeing these families being helped is the greatest reward.
My dreams of becoming a mom were to see her grow up and become the independent person. I never dreamt about keeping my baby at home. I wanted to see what kind of woman she was going to grow into. And I think that is the thing that is so motivating for all of us as families, is that we know who she could have been. We know who that child was. And research has told us that they can reverse that and we can help symptomatically, and that there's the hope that we could reach her again.
So thank you for watching that with me. I had the privilege of attending the IRSF meeting last week, and it was amazing. The first week was all basic science. Some of them were over my head, but it was very exciting to see what's on the horizon, how gene therapy is on the horizon for these kids. And to me, seeing that promise, seeing that light at the end of the tunnel for these families also motivates me. What can I do? So in our Rett clinic at the Autism Center, Thompson Autism Center, where we'll be starting soon, they do have an EEG machine there that we can use. So this motivated me to look at the literature as well and see, you know, with a routine study, for example, what can I do? What pattern should I look for if I decide to do EEG for my patients? And so this paper that just came out in 2022 actually was from Russia, but it was a very interesting longitudinal study on a case as well as their cohort in terms of what patterns on the EEG they see at different time points or at different ages in their cohort. So you see polyspikes here, and then you also see spikes, sharp waves with variable duration, and spike and slow waves. And you also see atypical absences in their cohort. And we do see that in children with Rett syndrome. So this is where I think also that where quantitative EEG can help us in quantitating not just the interictal burden. And as you can see, it's so diverse that I think a way to cohort these types of different epileptiform discharges and then looking at their developmental and neuropsych trajectory can help us study these kids better. And so with new medications, with gene therapy on the horizon, we have to have a measure of whether our interventions are effective or not, are helping these kids or not, or will harm them, right? So I think EEG is a cheap tool, but it is a very promising and important tool. So now I'm looking at Dr. Tarquinio. He was one of my mentors at Emory, and I give him a shout out for his excellent paper on the longitudinal course of epilepsy in Rett syndrome. So this is part of the Rett syndrome natural history study. They looked at participants with clinical Rett syndrome and those with MECP2 mutations without the clinical syndrome who were recruited from 2006 to 2015. So that's quite a long time. And clinical details were collected and cumulative lifetime prevalence of epilepsy was determined through the Kaplan-Meier estimator. And also they look at risk factor for epilepsy assessed using their Cox proportional hazards models. So those of us who are not very too savvy on statistics, I just put this out there, the methods that he used, because I think this could guide us if we decide to venture into analyzing our data. And they had 1,205 participants enrolled in the study, 922 had classic Rett syndrome, and 778 were followed longitudinally for a total of 3,939 person years. So that's quite a sizable amount of data. And to date, this is the largest cohort of patients that have been studied with Rett syndrome. And then they did write that the diagnosis of atypical Rett syndrome with a severe clinical phenotype was associated with higher prevalence of epilepsy than those with a classic Rett syndrome. So they found distinct seizure types. This is now for Retts. So there are a group of them who do not have seizures. And then there are also a group of them who have frequent relapse and remission. So some of them, they get enrolled, they have no seizures, and then during the study, they have a seizure, and then sometimes they can remit. So if their longest seizure-free period is 6 months, so remission is defined as 6 months additional in addition to the longest seizure-free period. So they can remit. And then there are those, unfortunately, who had relentless seizures. So for this group, now, this is a lot of data, but I just wanted to point out his basic points, that the point prevalence of epilepsy at annual visits ranged from 29.8% to 43%. 43.8%. So just a little bit less than half of them have present with epilepsy or seizures during the annual visits. And then seizure prevalence ranged by age group. So from 11.6% in less than 4 years old to a peak prevalence of 49.1% to the 16 to less than 20-year age group. And then they decreased thereafter in the adult cohort. So this is in agreement, I mean, similar to the ASD plus epilepsy cohort that Dr. Davinsky had also in his group, that it's the adolescence age where you see these peak of seizures, even so from the ASD and epilepsy, as well as the Rett group. And seizure semiology, it's similar as well, evenly divided between focal onset seizure in 46.8 and generalized onset seizures in 47%. Other seizure types occurred rarely. So you have the myoclonic, atonic seizures, and infantile spasms. So remember that table that I went through as well with you. So it's similar pattern as well. And they found that the seizure semiology was not significantly associated with age of onset, which is interesting, of epilepsy or the pattern of relapse or remission. So even if you have generalized seizures, that's not going to predict remission for the patient with Rett syndrome. And these are the other things that they looked at that had significant association with seizure prevalence. So somatic and head growth retardation were significantly associated with increased lifetime seizure prevalence. And so I tell my students or my residents, it's very important to follow the head circumference because that can guide you as to what to expect. And they may have it may be a prognostic indicator. And seizure prevalence was lower if height or head circumference was above the median. So for the Rett kids, we want them to have optimal growth, not just of their head, but also optimal growth of their body. And then weight in the upper quartile trended to lower seizure prevalence. So it is very challenging for the Rett kids. So they have G2, for example, that we have to make sure that they're meeting the weight, if possible, the ideal weight or ideal height and ideal head circumference, because that can actually affect their seizure prevalence, their risk for epilepsy. And so this is quite a busy chart here. They also looked at physical domains and different characteristics or pathologies that children with Rett syndrome have. And what was their conclusion from all these parameters that they looked at? So in the child's quality of life measures, where they incorporated it into a logistic regression analysis, they found that domains of physical role, so physical, let's say height, height, BMI, weight, and social limitations as well, and behavior and mental health were significantly associated with the presence of epilepsy. So this is just similar to when we looked at outcomes for people with epilepsy. The role of their psychological health, the role of problems with behavior and how we address them are also associated to the presence of epilepsy, and sometimes in the case of Rett, let's say in the remission pattern or relapse pattern. And Other things that they found that were interesting that were associated with epilepsy. Epilepsy was more common in those with a higher number of fractures. So we get into this chicken and egg argument, right? Are they having more fractures because they're having seizures and they're falling? I mean, that's a valid question, but they also looked at it the other way around. They just looked at the fractures as an independent variable, and they found that epilepsy is more common if they have increased fractures. So when we do prescribe medications, for example, like felbamate on these patients, we have to be cognizant about fractures and looking at their vitamin D to make sure that we're not increasing the risk for them. When age of seizure onset was considered using Cox regression, the frequency of hospitalizations, late age of diagnosis, bradykinesia, inability to walk, and G-tube feeding were independently associated with a higher hazard rate of developing epilepsy. So I think this just speaks to the severity of the pathologies of the clinical challenges that the child is facing. So interestingly, aggressive behavior was associated with a lower hazard rate. And I find this also in children, for example, who've had epilepsy surgery and their seizures are better controlled than before epilepsy surgery. There's almost like a frontal release phenomenon where they get more aggressive. So I don't know if this is related in the Rett's population. Maybe they're not seizing as much, so they're able to interact with their environment more. And this is just a pattern of the remission and relapse in classic Rett syndrome that they talked about. So main point, intractable epilepsy without remission, and those who experienced long-term remission began having seizures earlier. So earlier, median of 3 years. And the reverse is true. For those individuals who had seizure remission alternating with relapse had onset of seizure significantly later. So intractable epilepsy, earlier onset of seizures. So due to the wide variety of behaviors seen in Rett syndrome, spells of uncertain significance should be investigated with long-term video EEG or ambulatory EEG prior to starting medications. I think this is where this may change my practice in the future, is that before I start, I mean, we all do that though, we do neurodiagnostic testing, if we can, before starting medications, unless the wait is too long to get the EEG done. And although all patients had abnormal EEGs in this cohort, only 16% had electroclinical seizures during the recording. So this is a good point to know because you cannot rely on what you see clinically. And this is why the EEG is helpful. And parents, there is a discordance between parents and physicians with regards to spells and seizures. So about 8% of the time. So that's why the EEG is critically important to help guide us into which spells are seizures and which ones are behavioral, because we can't just keep adding on anti-seizure medications. Anti-seizure medications can impact non-epilepsy related behaviors, such as the motor stereotypies and breathing dysfunction in the Rett population. So in conclusion, why use the EEG as a biomarker for these neurodevelopmental disorders? It's because it's non-invasive and the temporal sensitivity is very good. And the method stability across different labs is pretty good. It can help us use paradigms but with consistent recording methods. So I think EEG meets the basic criteria for a biomarker. It is objectively measured, evaluated as an indicator of normal biological processes and pathogenic processes or pharmacologic responses to a therapeutic intervention. So meaning if we start a patient on ASM, how did they respond? How did their EEG improve? The interictal burden, the ictal seizures, did they decrease? So it's a good simple biomarker that's that's available everywhere. So I am open to questions.
Great, thank you so much. And Dr. Pichon, it's very illuminating. I'm not as familiar with Rett syndrome, so thank you for exploring that in more detail as it relates to ASD and epilepsy. We had a few questions. I don't know if we'll have time for all of them today, so if we don't get to your question, we'll follow up with you after the meeting. And Dr. Pichon has also expressed interest in following up with questions as well. I'll start with the question about how early EEG can be used to help diagnose some of these things and the correlation between ASD and epilepsy. I don't know if you have experience with that, but the person who asked the question expressed that it's important to diagnose these as early as possible to try to understand how these are going to impact the patient.
Right. So I'll go from the smallest to the biggest. So let's say for the Rett syndrome patients, some of them actually have seizures immediately after birth. So as we all know, neonatal seizures can be challenging. In that case, for this cohort, we do recommend doing the EEG earliest, if you have suspicion about epilepsy or seizures. For the ASD minus epilepsy who don't have epilepsy, some centers do it at 3 months, and sometimes they group it with their visual tracking paradigms as well. So as early as 3 months, you can do that for the ASD minus kids. The longer you wait, sometimes it gets very challenging for the ASD kids because they could be aggressive or they won't tolerate the EEG leads on their head the older they get. So as soon as you have suspicion, or if you are in the group that thinks we should use EEG as a screening tool for ASD, do it when you're able to do it with the kid, because you don't want to sedate the child for the EEG itself. So this is where routine EEG is helpful. It's short. And then I usually do rehearsals for these kids the week before. So first we have them use a hat or a beanie. That way it's not new for them when they come in for the EEG.
Great. Yeah. We have time for one more question. A few different people have asked this in slightly different ways, but they're curious about the localization of those focal seizures that you've seen in these different populations, and if there's been any area that you've found to be the most affected.
So most of the ASD kids that we do screening EEGs on, and I have a strong interest, for example, in ESES, some of them, most of them for the ASD minus epilepsy, the interictal discharges are mostly in the frontal and temporal regions. So that makes sense to see it in the frontal regions, right? Because their behavior is affected, social ability for executive functioning is affected. So that makes sense for the frontal involvement.
Okay, and I think you had a hard stop with us today, so thank you again for sharing information and presenting this today. It was very informative. We have so many people in the question and answer in the chat thanking you for sharing this with us. So we'll follow up. We'll post information about this on the Grand Rounds section of our Persyst.com in the support area. And you'll get an email letting you know when this is going to be available to you. So thank you all for joining. Again, if we didn't answer your question, we'll follow up with you after the talk. So thank you so much, everyone, for joining.
Thank you very much. Have a good day, everybody.
All right. Bye.
Bye.